In Chapter 3, we're going to look at our important antiviral drugs. This figure reminds us that there are a number of important targets for antiviral drugs. For example, we have drugs that target nucleic acid synthesis, others that target protein synthesis and processing, some that affect the entry of the virus into cells, and others that affect the virus in its ability to shed and infect other cells. So as we review the different drugs, this is a good figure to go back to help identify visually what their targets are. Similar to the figure we just covered, this table looks at the different mechanisms for our antiviral drugs. Unlike antibiotics, which I strongly encourage you to organize by the mechanism of action, antiviral drugs actually lend themselves to being organized by the type of virus that they're going to be used for. But this table does a nice job of summarizing the different drugs and the specific mechanism. I will also use this table and the box I've given you off to the right to remind you of common endings for antiviral drugs. In fact, many of our antivirals have the letters VIR at the end of their name, occasionally even in the middle of their name. If you see VIR, that's an indication, obviously, that it's an antiviral drug. But I will tell you, if the drug name ends with a VIR, you actually know the type of virus that drug is going to kill. Because AVIR drugs are AIDS virus drugs, good for HIV. On the other hand, IVIR drugs, I can stand for influenza. The IVIR drugs are influenza virus drugs. And finally, we have a number of drugs that end in OVIR. And all of the OVIR drugs are herpes drugs. Of course, for oh my God, I got herpes. So OVIR drugs are herpes drugs, IVIR influenza, and AVIR drugs, AIDS virus drugs for HIV. We'll start with our antiherpetics, and the prototype drug here is acyclovir. Notice the OVIR part of its name. The mechanism of action of these drugs is very, very important. All of the OVIRs work the same way. Let's say it like this. OVIRs are anti-metabolites. They look like a metabolic product in the body. In fact, the OVIRs are nucleosides. They're nucleosides, but what they really want to be is nucleotides. So they have to be phosphorylated to become nucleotides. How we add those phosphates is really critical to understand. The first phosphate is added by viral thymidine kinase. Okay, make sure you caught that. I just said herpes adds the first phosphate to the OVIR. Herpes helps to activate the drug that's going to kill it, so we thank herpes for that. But in order to add phosphate number 2 and phosphate number 3, the virus doesn't help with those two. That's where host cell kinases add the second and the third phosphate. So the active form of acyclovir is acyclovir triphosphate. It's both a substrate for and an inhibitor of viral DNA polymerase. After all, herpes is a DNA virus. It turns out, though, that all of the OVIR drugs work as chain terminators, and we're going to look at their property that contributes to chain termination in just a moment. When you think of resistance to the OVIR drugs, it's quite easy to remember as long as you remember how did we add the first phosphate. The first phosphate was added by viral thymidine kinase. So strains that lack thymidine kinase, we label those as TK- strains. They're going to be resistant to all of the OVIR drugs, not just acyclovir. This figure does a very nice job of illustrating the mechanism of action for OVIRs. Also shows us how our NRTIs work. Remember, NRTIs are nucleoside reverse transcriptase inhibitors, drugs used for HIV. We're also going to look at the mechanism for NNRTIs and another antiviral drug called Foscarnet. Let's start with the OVIRs. OVIRs are inactive prodrugs. Remember that they are nucleosides that need 3 phosphates in order to become nucleotides. The first phosphate is added by viral-specific thymidine kinase from herpes, but the second and third phosphate from the host. Now this is different from what happens with an NRTI. The nucleoside reverse transcriptase inhibitors all want to become nucleotides, so they also need 3 phosphates added. But here's a question for you. Does HIV add any of those phosphates like herpes did? The answer is no. Herpes helps, but HIV does not. So who adds all 3 phosphates to an NRTI? The answer is host kinases. But here's an additional similarity. You'll notice that both ovirs and NRTIs inhibit DNA polymerase. Except in the case of NRTIs, another name for reverse transcriptase is RNA-directed DNA polymerase, so a common target for each of those types of drugs. Both ovirs and NRTIs can cause chain termination because they have the same structural characteristic. These drugs lack 3' hydroxyl groups. Remember, in order to catalyze the addition of the next nucleotide, you need a 3' hydroxyl. So if you take acyclovir triphosphate and incorporate it into a growing DNA chain, it results in chain termination. You see NNRTIs listed here as well. Those are non-nucleoside reverse transcriptase inhibitors. They're drugs that don't require phosphorylation. They can directly inhibit RNA-directed DNA polymerase, or reverse transcriptase. Similar foscarnet can directly inhibit DNA polymerase without needing to be phosphorylated. It's an active drug as given, and so it's another one of our anti-herpes drugs, but it is not a prodrug. It's not an anti-metabolite. When you look at the uses for acyclovir, its uses include herpes simplex and varicella-zoster virus. In fact, the shingles question is very popular on the exam. If the question is about killing the virus, then acyclovir and other ovirs are very useful. However, what if you have a patient with shingles who's complaining about the pain of shingles, otherwise known as postherpetic neuralgia? The antiviral drugs are not going to stop specifically the pain. So to treat the postherpetic neuralgia, we look for drugs like gabapentin, pregabalin, or perhaps even our tricyclic antidepressants to treat postherpetic neuralgia. When you look specifically at acyclovir, a disadvantage of this drug is that it has a short half-life. You have to take it multiple times a day, as many as 5 times a day in fact, to use it effectively as an antiviral. So a lot of the newer ovir drugs for herpes have been developed because they have longer half-lives and you don't have to dose them as often. So we can certainly use these types of drugs to reduce symptoms if used early in chickenpox or prophylactically in immunocompromised patients. When you think about side effects for acyclovir, generally they are very minor. If you take this drug IV, and certainly if you take it chronically, there's a greater risk that you might get crystalluria. So the patient, if they're taking this drug, should drink lots of fluids, keep them well hydrated to avoid this side effect. It's interesting that in our notes we highlight the fact that acyclovir is not hematotoxic. You know, it's not a lot of things, but one thing that acyclovir doesn't do is cause bone marrow suppression. That's called a setup, folks. That means that we're about to discuss an ovir that does cause bone marrow suppression. Hang on, we're almost there. The newer drugs in this family, famciclovir or valacyclovir, have the advantage of longer half-lives, but otherwise have the same properties as far as mechanism and the same resistance characteristics as acyclovir. When you look at the drug ganciclovir, it's very similar to acyclovir with regards to mechanism and with regards to resistance. But when I think about this drug, there are 2 specific differences that I want to point out between ganciclovir and all of the other ovirs. We'll look at those on the next slide. The first key difference between ganciclovir and acyclovir is not only can we use both drugs for herpes simplex and varicella zoster, but ganciclovir is used for CMV, cytomegalovirus, which often manifests as retinitis. We see CMV show up as patients' CD4 count declines. In fact, CMV is one of the last opportunistic infections to show up as you're becoming immunosuppressed. Your CD4 count has to be down around 50. So remember, CMV and MAC are the last two of the opportunistic infections to show up as you're becoming immunosuppressed. So we can use ganciclovir as prophylaxis and treatment of CMV, including retinitis and AIDS, and also in transplant patients. And here is the second difference between ganciclovir and acyclovir. Ganciclovir is the one that causes dose-limiting bone marrow suppression, including leukopenia and thrombocytopenia. It's why some people remember you modify the name of this drug. Instead of calling it ganciclovir, you call it gangcyclovir, because it gangs up on your bone marrow. Remember, that's a key distinguishing feature when you think about this drug compared to the other Ovirs. If you're taking ganciclovir, you still want to keep the patient well hydrated because of a risk of crystalluria. Okay, let's see if you can answer this question. Which herpes drug is not like the others? So there's Ovir, 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 and Foscarnet. I would say that the one that's different is Foscarnet. Clearly it's not an Ovir, and it's a way for us to remember that this drug has a slightly different mechanism of action. It's not an antimetabolite, meaning it's not a nucleoside. The drug does not require phosphorylation. You see, this drug is active as given. It can directly inhibit DNA polymerase. But of course, since Foscarnet does not require phosphorylation, that means it does not care if the virus lacks thymidine kinase. That's a real key. Foscarnet still works on TK- strains of herpes, so you can use it in acyclovir resistance. People who take Foscarnet need to be aware of dose-limiting nephrotoxicity. You can possibly get acute tubular necrosis, and you also get electrolyte imbalances, including hypocalcemia. So be aware of the side effects and the electrolyte imbalances this drug might cause. Now that we've finished our discussion of antiherpetic drugs, let's move on and talk about drugs for HIV. One of the most classic group of drugs for HIV are the reverse transcriptase inhibitors. These are the original inhibitors of reverse transcriptase, and they're all nucleosides, with zidovudine as the prototype. As we saw in an earlier figure, these drugs are going to require phosphorylation to their active form. Specifically, let's think about the nucleoside reverse transcriptase inhibitors. These are the drugs that require phosphorylation in order to be active. Oftentimes, an NRTI is used together with a protease inhibitor. Combination therapy is the rule for treating HIV. We call this highly active antiretroviral therapy, also known as HAART. HAART therapy can result in decreased viral RNA and reverse the decline in CD4 cells. All of those opportunistic infections that might occur as you're becoming immunosuppressed, in fact, are responsible for the morbidity and possible mortality with HIV. We have another group of reverse transcriptase inhibitors known as NNRTIs. And the NN component is very important because that stands for non-nucleoside. These are drugs that don't require phosphorylation. They're active as given. They're analogous to the drug Foscarnet that we covered in the previous section. Among the NNRTIs are the drugs nevirapine and efavirenz. If you look at efavirenz, right in the middle of its name it has the letters AVIR. So it's my favorite drug. It fits the naming convention. Nevirapine, VIRA, it's a little dyslexic, but it still has all the letters in there nonetheless. These drugs, as I said, are active as given because they inhibit reverse transcriptase at a site that's different from the one that our NRTIs bind to. They are often used in combination either with an NRTI or with protease inhibitors for an additive or perhaps a synergistic effect. Let's go back and think about the NRTIs. Zidovudine is our prototype. Now, the chemical name for this drug is azithromycin. It reminds us that it's a thymidine analog, but it's also why we come up with the abbreviation for this drug, which is AZT. Because based on the name zidovudine, you can abbreviate that as ZDV. On your exam, I expect them to either use the word zidovudine as the name of the drug or its most common reference, which is AZT. We've reviewed the mechanism, which is you have to add 3 phosphates in order to activate this drug. In the end, If you incorporate zidovudine triphosphate into the growing chain, you get chain termination. Resistance to zidovudine occurs by mutations in the gene that codes for this enzyme. When it comes to the other NRTIs, their mechanism is identical to that of zidovudine. Each of them requires 3 phosphates in order to form nucleotides to inhibit reverse transcriptase. The resistance mechanisms are similar, but we don't have complete cross-resistance between different NRTIs. So just because you've developed resistance to one NRTI or perhaps a combination of NRTIs doesn't mean that you can't use other drugs out of this group. The key is that the NRTIs differ in their toxicity profiles and their ability to cause bone marrow suppression. AZT, zidovudine, is the one with the greatest risk of bone marrow suppression, and all of the other NRTIs are going to have less of an effect on the bone marrow. When I look at this table for side effects of NRTIs, there's a couple of specific test questions that I see here. One is that bone marrow suppressive effect of zidovudine. That's the major and dose-limiting side effect of this drug. For the NRTI known as didanosine, watch out for pancreatitis. This is the major and dose-limiting side effect of this drug. Down at the bottom, lamivudine and M-tricytidine are both considered the least toxic of the NRTIs, which makes them our most popular drugs today for use in combination therapy. If you're thinking, why don't we just use lamivudine and M-tricytidine at the same time? There's a real problem with using those two drugs together. Turns out that both drugs are cytosine analogs. And if you use 2 cytosine analogs at the same time, the drugs actually compete against each other, and that's not effective. A basic rule is to use different nucleotides as part of your combination. So choosing a drug like lamivudine and combining it with zidovudine is much more effective, even though you have a higher risk of toxicity. If I'm looking for kind of a general side effect among the NRTIs, peripheral neuropathy is a common side effect for the group. So I have to be aware that patients may experience some pins and needles sensation in their extremities as an indicator of peripheral neuropathy while on an NRTI. In the margin is a clinical correlate about the drug tenofovir. Tenofovir is different from the other drugs we've just discussed. It is a reverse transcriptase inhibitor, but it's a nucleotide reverse transcriptase inhibitor. This has become a very, very popular drug. In reality, tenofovir has a single phosphate on its sugar residue. It still requires 2 more phosphates to become triphosphorylated. Of course, those 2 phosphates are added by the host. I like to think about it this way. Tenofovir has a head start compared to NRTIs. It already has 1 phosphate. It's become very popular to use tenofovir in combination with drugs like lamivudine or M-tricytidine. Another classic group of HIV drugs are protease inhibitors. These are drugs that inhibit the aspartate protease enzyme that is involved in cleaving precursor polypeptides in HIV. Basically, by blocking this enzyme, you prevent the maturation of the virus. Resistance to protease inhibitors occurs when there are specific point mutations in the Pol gene which encodes for protease. There's not complete cross-resistance between the different protease inhibitors, so if one of them fails, you can certainly try another one. When I look at the names of the protease inhibitors, I recognize that all of these drugs end in the letters AVIR. So these are the AVIR drugs, where ritonavir is our prototype, and it's certainly our most popular drug. In fact, today, we very often use 2 protease inhibitors at the same time, with one of those drugs being ritonavir. The second could either be lopinavir, atazanavir, or darunavir. And we'll talk on the next slide about why you would do a co-formulation with those drugs and ritonavir. The reason why ritonavir is our most popular protease inhibitor today is because it's a P450 inhibitor. Now, if you're surprised by that, you should be, because most often when we think about drugs being P450 inhibitors, we're very concerned about drug interactions and the fact that inhibitors are going to raise the plasma levels of other drugs, leading to side effects. But here's a case where we clinically take advantage of a P450 inhibitor because of its ability to raise the levels of other drugs. In fact, the action of ritonavir has been referred to as a boosting effect. The term booster means ritonavir increases the plasma levels of other protease inhibitors. So if you take ritonavir, combine it with a second protease inhibitor, you actually get higher levels of the second drug. In fact, clinically we found that to be very, very useful, so this is common practice. Another protease inhibitor, indenavir, is a drug that might cause crystalluria. So once again, we see this commonly with antivirals. Keeping the patient well hydrated can be a useful strategy. Here's another popular question about protease inhibitors. The fact that long-term use of protease inhibitors can cause the syndrome of disordered lipid and carbohydrate metabolism. The patient presents with central adiposity and insulin resistance. Remember, whenever you see the term insulin resistance, always think of hyperglycemia. In fact, these side effects of long-term protease inhibitors remind me of what steroids do, because long-term steroid use causes fat deposition and hyperglycemia as side effects. In the margin is a clinical correlate about HIV prophylaxis. Today, post-exposure prophylaxis is most likely to include M-tricytidine, remember the least toxic among the NRTIs, plus tenofovir, the NTRTI, and raltegravir, a drug that we're about to discuss. It's an integrase inhibitor. In pregnancy, 2 NRTIs, we choose from either M-tricytidine or lamivudine. Add that to either zidovudine or tenofovir, and then we add 2 protease inhibitors, ritonavir with one of our other options like atazanavir or lopinavir. So typically that's a 4-drug combination. One of the newer drugs for HIV are the integrase inhibitors. These are drugs that block HIV integrase, preventing integration of the viral genome into host cell DNA. The drug we mentioned in our notes is raltegravir. Make sure you know this drug. In fact, there are 2 parts of its name that remind you that it's an HIV drug and perhaps even help you with its mechanism. It does end in the letters AVIR, AIDS virus drug, but in the middle of its name are the letters TEG. Perhaps TEG reminds you that it's an integrase inhibitor. So integrase and HIV, you can put those 2 things together by looking at the name of this drug. We have a couple of fusion inhibitors we can look at as well for HIV. Infuvertide is a drug that binds GP41 and inhibits fusion of the virus to CD4 cells. This was the original fusion inhibitor, but it's actually dropped down in favor of the second drug, Maraviroc, today. Maraviroc, a drug which has AVIR in the middle of its name, so that's helpful, blocks the CCR5 protein on macrophages. Basically, by doing that, it blocks the binding of the GP120 HIV protein to CCR5, and that prevents viral entry. And this drug has become very popular today. Make sure you know both of these mechanisms for your test. Let's look at some other antiviral drugs, including the drugs zanamivir and oseltamivir. It's easy if you look at the ending of these drugs' names. You see the letters IVIR, I for influenza. The drug oseltamivir, known as Tamiflu, is a very, very popular drug today for influenza. The mechanism for these drugs is that they inhibit neuraminases, enzymes that are involved in shedding and release of the virus, and if you block that enzyme, you inhibit the ability of the virus to infect other cells. The inhibition of neuraminidase happens in influenza A and influenza B. As a result, these drugs are very, very effective for those forms of the virus. You can use them prophylactically or as treatment. If you're going to use them as treatment, make sure you give them as soon as possible after the onset of symptoms, because after 48 to 72 hours, these drugs are much less effective. In the margin is a clinical note about some drugs that we used to use quite often for influenza. Amantadine and rimantadine are no longer recommended as prophylaxis or treatment of influenza A viruses. Greater than 95% of the circulating strains of influenza A are resistant to these drugs. Notice that these drugs never really worked on influenza B. The specific target for these drugs was only found in influenza A. It was certainly a difference between these two and the Ivir drugs, which target influenza A and influenza B. The next drug to look at is ribavirin. Unfortunately, this drug's name presents a couple of challenges for us. It has AVIR in the middle of its name, but it's not an HIV drug. In fact, this drug is used for RNA viruses. The mechanism of action is that it has to be monophosphorylated to a form that inhibits IMP dehydrogenase. If you convert it to the triphosphate form, it inhibits viral RNA polymerase and end-capping of viral RNA. The clinical use of ribavirin has been limited by its side effects, but we still use it today as an adjunct to alpha interferons in hepatitis C. We think about using this drug for the management of RSV, but today it's very much reserved only for severe cases and only in adults, because we have another drug called palivizumab that's used for prevention. This is a drug that binds to the RSV protein and is useful in high-risk kids as a preventative. The side effects are bone marrow suppression that very much limits the use of ribavirin. We end this chapter by looking at hepatitis C treatments. As we mentioned on the previous slide, interferon alpha plus ribavirin is certainly useful, but we have some new drugs here. Sofosbuvir is a nucleotide analog that inhibits RNA polymerase and can be used in combination for hepatitis C. Cimeprevir or telaprevir are also hepatitis C drugs, but they work by inhibiting hepatitis C protease. Like the others, they can be combined with ribavirin or interferon alpha.